I'm Susan Kavinsky, your host of End of Life Rounds. This podcast is a space for exploring conversations about end-of-life care, support, and the human experience surrounding it. Through each episode, we aim to bring clarity, perspective, and a deeper understanding of what this stage of life can look like. End of Life Rounds is brought to you by Golden Gate Hospice Care, where care extends beyond medicine to support patients and families in a more thoughtful, human way. In today's episode, I'm joined by Dr. Jessie Lucey, a family physician working in end-of-life care. Together, we explore palliative care, hospice, and medical aid in dying, and how both cultural and clinical perspectives are shifting toward earlier, more patient-centered decision-making. We also discuss the importance of introducing palliative care earlier in chronic and terminal illnesses, and how expanding access can create more space for planning, connection, and support. This conversation also touches on the psychological and relational impact of early acceptance, from navigating family dynamics to creating more meaningful final moments. Thank you for being here.
I'm very curious about the whole thing, the whole experience and how it works.
Absolutely. I've been really enjoying exploring this field of medicine. So I'm a family doctor, which means, I get to do kind of anything that I like that involves humans. And I've really been getting into end of life care specifically because, of course, it's the most inevitable thing in the world. And I feel like America is really finally dragging itself into a conscientiousness about death and about how dying is an inevitable process, but it can also be a very powerful and important process and really meaningful process, just as meaningful as birth. And so when I hear phrases like death doula, which is really just this profession that's coming into its own, I get really excited because I feel like we're finally treating death with the respect it deserves.
Absolutely.
And so the part that I play in it is so small, but it's a part that's very important for some people. I think in terms of what medicine can do better in the future is implementing palliative care so much faster in the process than we are doing.
Right.
My personal opinion, well, personal and professional opinion, is that as soon as we're talking about a chronic disease, we should be talking about palliative care, especially if it's a chronic and ultimately terminal disease. Palliative care should come immediately. Then if hospice is a very specific subset of palliative care. So hospice is palliative care that happens in the last 6 months, which allows us to be more aggressive and more creative in how we are making people comfortable. And then yet another subset of hospice is medical aid in dying specifically. So we all know that people do wonderfully with hospice. People who are on good hospice, their symptoms better controlled and are able to have a higher quality of life, which often paradoxically leads to a longer quantity of life.
Right.
People do better on a hospice than they do with what you might call traditional medicine, traditional curative medicine.
I would say that it's not even counterintuitive if you think about it for a minute, right? Whenever you face your fears directly, your quality of life is going to improve. And I think that's one of the reasons why it doesn't even make sense to me that hospice is only like the last 6 months. I mean, if you have a condition like Parkinson's or ALS or something like that, where you know how it's going to end, you just don't know how long it's going to take. I don't see why people in those circumstances couldn't be in hospice care already, right? As in hospice being the preparation for, right? As soon as you get that diagnosis, psychologically, you're in preparation.
100%. And you could solve that either by allowing people to be entered into hospice earlier or just by lifting up palliative care. I don't care which way you go.
Right.
Either way, there should be some acknowledgement of the fact that you have entered into an ultimately terminal condition, and maybe we should start dealing with that.
Right. It hurts my heart when people try to pretend is not happening. Right. I had a client we sang for, the granddaughter ran down the hallway to greet us and tell us she doesn't know what's happening. And I was like, Oh, but she probably does.
She probably does. She
Yeah.
probably does. She knows somewhere. If she's paying even a
Yeah.
little bit of attention, I bet she
And
knows.
she was bright. I mean, I didn't speak her language and she didn't speak my language, but when we met eyes, there was a lot of communication that she knows a lot more than she's telling.
Yeah. I
Because
bet
she's
she's
taking care of them, their feeling, and they're taking care of her.
and
Her
knowing
feeling.
being able to express their true feelings about the situation, which could possibly be healing for everyone.
Everyone. Right.
So unfortunate.
Mhm.
Um, and I think what I've mentioned about medicine and hospice should become a little bit more prevalent in medicine. That's, of course, addressing one aspect of it. What you said is when people know what's going on and they can face what's going on head on, they do better, which makes so much sense. So I see palliative care and hospice is really acknowledging something that's going on from a medical perspective. But of course, there's so many other components of it. There's the emotional, spiritual, mental component of it that can sometimes be addressed in the medical field, but sometimes really benefits from chaplains, from death doulas,
Right.
from therapists. There's a whole other roster of professionals who can really be so tremendously helpful in the dying process,
Right.
who often aren't called in early enough
Right.
because there's this distance created between the patient and death.
There's the family dynamic aspect too,
Mm,
because it's happening to everyone. Yesterday at UCLA, someone said, "Oh, he's been through such a difficult time. He's been through a 15-hour surgery." And I thought, and so have you. So have you
yes.
been through a 15-hour surgery,
Yes.
right? But instead, I just say things like, "We think for you as well."
Mhm. Mhm. And the same thing in the dying process. This is a terrible thing to be happening to the patient and to the entire family, regardless of its inevitability for
So that
everyone.
brings me back to the conscious dying aspect.
Yes.
Is that I don't feel like, I know, if you can die consciously, it can be a gift to everyone. And if you die in kind of I hate to say it this way, but this is how I think of it, as kind of almost a medically induced coma,
Mhm.
then it's not as much of a benefit as it could be. And I'm not advocating for people to have pain. It's not that. But I am advocating for people to be willing, and I think we need this in the entire culture, for people to be willing to face our impermanence.
Mm. So
And
true.
I think our entire culture is death phobic, and that negotiates so much
Mhm.
when it really doesn't need to. Like you could have an unmediated experience
Mhm.
of your loved one in their final moments. It would be better than if we're all putting our terror between us and them, and then you've created an us and them
Yes.
out of that fear.
Completely agree. Obviously, I completely agree.
Yeah, obviously. I know, I like to preach to the choir.
Very much so. Specifically, I think that medical aid in dying has, in the 10 years that it's been legal, at least in California, has really benefited two incredibly large groups of people. First off, are people who don't benefit as much as they should from hospice. Good quality hospice care can alleviate an enormous amount of suffering, but sometimes our medications just aren't as nuanced as we need them to be. People with shortness of breath can suffer tremendously despite morphine and Ativan. Some people have terrible reactions to the existing medications. They get terrible nausea or terrible constipation that really makes the pain medications unusable for them.
Right.
And so for those people, because their pain and suffering aren't being adequately alleviated by hospice care, medical aid in dying can be an enormous relief.
Mhm.
It can put an actual end to their pain and suffering in a way that hospice was unfortunately, for whatever reason, not able to. So,
I think it does something else too that's more subtle and in ways just as important. When a person takes control of their lives like that, control of their death like that, they're taking control of their lives as well. And then they have the consciousness from which to plan, right? To plan conversations, to plan how things are going to go. It's all so conscious as opposed to the denial of death, where it's also, I don't want to talk about it.
mhm,
Once you've accepted it, right? It can be
yes,
such a gift.
I agree. And so, in the same way that medical aid in dying can alleviate pain and suffering, physical pain and suffering that are
Mhm.
not be alleviated by traditional hospice medicines, it can also really alleviate existential suffering.
Right.
As you say, it forces you to accept your death and allows you to plan for it. I've had
Mhm.
people close down their bank accounts, order extra copies of their death certificate, rewrite their wills at the last second. It
Mhm.
really gives people this permission to finally get their affairs in order, something that I believe everyone should have in order now, right
Right,
now.
right, but we wanna pretend that's not gonna happen to us. It's gonna happen to everybody else, but
Completely.
it's not gonna happen to me. I've seen people have their own memorial service
Oh, it's a beautiful.
before they die.
Oh, it's gorgeous. I've had so many people remark upon the fact that it's so unfortunate that you have to wait until after your funeral to have people say nice things about you when you're not even around to be able to appreciate it.
And feel all that love that they actually have, because one of the things that happens when someone dies is people let go of their stories about the person. They let go of their grievances and their reaction patterns and all the things that come between us and our loved ones, right? And then it's just the naked person, mom, and the naked person, daughter,
Mhm.
and those people can meet. And that's what happens in a memorial service after someone's gone. But what if it would have happened for you before?
Mhm.
Even if it's just like a meeting in a bedroom and not a memorial service, it still can happen.
Well, and I've seen both extremes. People plan
Mhm.
their own memorial services, which can be, as you say, incredibly powerful and uplifting. But sometimes it's as simple as having the family gathered around the bedside and
Right.
the last 10 minutes between the time that they drink the medicines and fall asleep. They really just get a chance to think about what's really important. What is
Right.
the most important thing to say to this person in this moment? And of course, all the time before then, as you're planning the event.
Mm.
So it can be quite formal, it can be quite informal, but I've never seen it be anything except uplifting and healing.
In my experience with spiritual development, that it's what comes about when you face your own death, and that those spiritual crises really are little deaths preparing us to let go of our bodies. But if you've accepted that already, and if you're doing medical aid in dying, you have definitely accepted that already.
Yeah.
Then there's this transcendent thing that can happen. I had a friend who was so self-realized by the time she died that in her hospital room in a very busy metropolitan hospital, every doctor put their stuff down at the door and just came in to be in her presence. It was like so beautiful to be in her presence. And if somebody came bustling in the room, she'd put her hand up like this and she'd just go, please go back out 10 seconds, take a breath, and then come back in. And
Mhm.
everyone she asked to do that did it.
Sure. I
She
think there
was
is
so beautiful.
that is beautiful, and I'm sure that in the hustle and bustle of a hospital, there is still profound respect for the dying process, and I'm so glad
Absolutely.
that you manifest that.
That's the only thing I ever see is profound respect.
Yes.
Yeah,
That's
it's when we were at UCLA yesterday, times have changed. The patient we were going to sing for, the woman came out who had just she works for UCLA too. She had just given him Reiki. And the next person we went to, she came out and she said, "I just did a meditation with him." And I'm thinking, "Wow, wow, wow, things have changed. Yeah,
yes.
things have changed." This
And
is
it's
a busy ICU too, where this is what they value, and they had us sing for a class of new, nurses, one time. Yeah, after we sang the Ram Dass, we're all just walking each other home.
oh, beautiful. So that they
Yeah.
can also appreciate just intrinsically, but also what they're able to offer their patients.
Right, right.
Lovely.
I feel this huge shift happening.
And thank goodness we have so many tools that we can use during the dying process. We should be throwing everything at the wall and seeing what sticks. Rather,
Mhm.
offering as many different modalities as possible, and how beautiful that we're finally starting to do that.
I think also, if you open up hospice earlier, and, I think Dr. Arash has told me that the vast majority of people that come into his hospice are at the very end,
Yes.
and
Yep.
how unfortunate, how absolutely unfortunate that is. Um, I think if you open it up even more, um, you're going to bring down the cost of medicine. You're going to bring down the tendency toward these huge heroic things that maybe going to buy you a day and a half. And usually that day and a half is a day and a half of absolute misery.
Yep. Yes.
That people are just waking up to, how valuable hospice care can be.
Oh, I strongly agree. Hospice should be offered as quickly as possible. And like I said before, palliative care should be offered immediately.
Right.
It should be so much earlier, and hospice should also be earlier. We
Right.
should be starting this process, whenever it feels right, which is much sooner than what we're currently doing.
And very much more up to the patient
Mhm.
than the doctors or the medical staff. It's the patients that's going to decide those things.
Of course. And it's a slow shift from patriarchal medicine to patient-centered
Thank
medicine.
you for saying it.
Yeah. But I am seeing that in the way that you've seen new modalities popping up in the hospital and the
Exactly.
for the dying process. I am seeing that shift from patriarchal medicine to patient-centered medicine, and I just love it.
I do too, and I love that you brought that up because this is my area of focus and it's what I write about, is this shift from a domination culture,
Mhm.
right? A culture that wants to dominate everything to the point that we even want to dominate death, to throw everything at not dying that we can, and then it's a failure if the patient dies anyway. It's kind of like, that's so crazy.
It's an insane focus, and
It is insane.
the ultimate patient-centered decision. It is, it's so tricky to admit in medical circles because the American Medical Association was traditionally against medical aid in dying, is
Right.
slowly coming around, but it is the ultimate respect of a patient's autonomy and of their knowledge of their body. We say, okay, this is what we think you should do, but we also acknowledge that you might not want to do that, and you should have that option. And I
Right.
think it's beautiful.
I can't, in some ways, believe that it's only been legal for 10 years here in California. I mean, that's kind of wild to me.
That's wild. And, I'm sure you know the saying that it takes 10 years for medical knowledge to become mainstream.
Yeah.
Once we figure something out, it takes 10 years for doctors to actually start doing it.
Right.
And I feel like we're seeing that. There's been, it's been going on for 10 years. I still speak to people all the time who don't know that it's legal. So,
Right. So
which
let's talk about that. That's a beautiful segue because I think a lot of people that are going to land on this podcast are going to be people in the situation or who have family members in the situation or who someone in the middle of the night who's like really thinking about it and lands here. So it would be great if you could like talk us through what's necessary, if someone, even if they starting with just finding out more information.
very much so. So, as you said, the process has been legal for the last 10 years and very little has changed to the law. The most important thing that has happened is that the waiting period has shortened. Other than that, the law has remained basically unchanged since it was legalized in 2016. And unfortunately, despite it being legal for 10 years, we still haven't managed to get it covered by insurance unless you happen to belong to a larger institution. Kaiser, UCLA, USC, they have their own medical aid and dying programs, which is wonderful. And Medi-Cal, with very certain provisions, will cover the medications, but otherwise, it is very difficult to get this covered by insurance. Fortunately, all the doctors I know offer a sliding scale, myself included, because we strongly believe that this is a service that should be accessible to everyone, regardless of their socioeconomic status at their time of death. So the process itself is, I would say, straightforward because I've done it a number of times, but it can feel a little bit overwhelming for the person first coming to it.
Yeah.
Usually it starts with a person receiving a terminal diagnosis and often a referral to hospice. So that is to say they've received a diagnosis that is terminal and a prognosis of less than 6 months. At that point, a referral to hospice usually happens, but the patient may independently decide that they'd like to pursue medical aid in dying, which is completely their choice. What they have to do is they have to meet with two different doctors, separated by at least 48 hours. They have to have two independent physicians evaluate them to determine that they have a diagnosis that is terminal, they have a prognosis of less than 6 months, and very importantly, that they are of sound mind. You have to be of sound mind for both physician visits and at the time you take the medication.
Huh.
This is one of the most common questions I get. there are a number of people, myself included, who are really terrified about the existential crisis of having dementia.
Mhm.
And a lot of people ask, if I have dementia, can I do medical aid in dying? And more often than not, the answer is no,
Mhm.
because you're
Right.
usually not
I was
accessible.
wondering how we define sound mind.
Right. And it can be a little bit of it's an open-ended definition. Basically, during the conversation that I have with a patient, I feel pretty clear in determining whether a patient is of sound mind. When I ask the question, why is medical aid in dying the right option for you? People will say things like, I'm suffering greatly. I'm not able to do the activities that I usually like to do. My quality of life is no longer acceptable. I've never had anyone say this, but if they said something like, "The aliens made me do it," talking about something else. And I've also had patients who are in the later stages of their disease who can't focus enough to answer the
Right.
questions.
Right.
And unfortunately, that means it's too late for them. They've passed that really key time when they're of sound enough mind to have the conversation and make the decision and be seen by myself to be able to make their own decision.
So here's a question on that.
Mhm.
Um, can a person with dementia, say, preemptively have these conversations and then wait a while? Like, is there a time limit from when you get your prescription for the medications to when is there an expiration date on the shoe consultations?
We are working on advanced directives for dementia patients or
Yes.
dementia, and legally, no state has yet been able to make that fly. So, unfortunately, for the moment, there's no way to do advanced directives if you have dementia, which breaks my heart and that of many of my patients who have requested it.
Yeah. So I'm
Yeah.
thinking about getting around the advanced directive thing by having the meeting with the physicians and getting the medicines.
Yes. Unfortunately, the medicines themselves expire after 6 months.
Yeah.
And if, of course, if you waited years and years to take them, that means that likely your doctor was fibbing when they said that your prognosis was less than 6 months.
Right. And that would be a problem for the doctor.
It
Yeah.
would. Interestingly, there hasn't been a legal case brought against a medical aid in dying physician since its legalization,
Mhm.
and that's because our strange litigious system awards settlements based on years of useful lives lost, and someone in the last 6 months of their life, therefore, wouldn't have a sufficient settlement to make it worth a litigator's while,
Right.
uh, which is not. I don't agree with our litigious system most of the time. But as a medical aid and dying physician, of course, that's very helpful.
Right.
But I wouldn't bank on it, and I certainly would never do anything illegal.
Right. Of course not.
Of course not.
So Alzheimer's patients now are really at a disadvantage. Um, what about everybody else?
The most common diagnoses that we see in medical aid and dying are diagnoses of cancer
Mhm.
and ALS, Lou Gehrig's disease, because these have a really predictable trajectory,
Mhm.
and you tend to be lucid up until the moment that you're suffering too much to want to continue living.
Right.
So that is really what medical aid in dying is the most helpful for. I've also had patients with other neurodegenerative diseases. Congestive heart failure is a big one because, as I mentioned before, shortness of breath can be an
Interesting.
incredibly troublesome symptom.
Yeah, that's what my mother died of. It was terrible.
Yes, I'm so sorry to hear that because it is terrible. It's not a nice way to go,
I
unfortunately.
think if she could have had the option for medical aid in dying, she would have. I know she would have. she
Yeah.
she tried to make me promise one day that if she was ever on life support, I'd pull the plug between my toes and yank it when no one was looking. So I'm certain she would have chosen that option. She didn't have that option though.
That is actually how I got into this list recently is my best friend's grandmother was dying of congestive heart failure. Every day she woke up and said, I'm really ready to go. I
Yeah.
really want to go. And my best friend asked me if I was able to prescribe those medications. And at the time, I had just moved back to the state. I didn't have my paperwork in order.
Hmm.
And it broke my heart to tell her, look, I know this is legal, but I don't have this set up yet. And that was the motivation for me to get back into it. Um, and I'm really glad I did. Ultimately, my best friend's grandmother died a week later, but she would have been so happy to be able to take those medications earlier.
Yeah, because that's a whole week of real suffering.
Of unnecessary suffering.
Right.
We
Right.
really we have these powerful you mentioned earlier the possibility of going into a medically induced coma. And while that is, that is often something we end up doing a lot of times, that is to say, giving someone morphine until their pain goes away with the knowledge that it will make them very sleepy and possibly unconscious and probably die earlier.
Right.
It's always an option. And that's an option in any state and in almost all countries that I know of.
Right. And it's
But
a
it's
common outcome.
Yes, but I don't find it particularly sophisticated.
Mm-mm.
And most people say, "Well, why would I do that? Why would I treat my pain to a point where at which I'm no longer conscious? What is the point of that? Why am I just dragging out this period? What am I doing? What are we
Well,
accomplishing?"
but that brings me back to culture again, right? To our death phobic culture, because that's the why.
Yeah, it is.
Because because mumble, 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 God, mumble, mumble, mumble,
Sure, mumble,
yeah,
mumble, the doctor
right,
should preserve
yeah,
life,
right,
ending.
right.
Yeah,
So
yeah.
it's a belief system that we're really not have not been that willing to examine.
Mhm.
It's like and it's connected to the if you commit suicide, you can't be buried in the churchyard
Sure.
kind of consciousness, religious consciousness that somehow dying by suicide is the very worst thing, the biggest affront to God that you can do.
Sure. Sure.
And all of that is unexamined in
Mhm.
the decision and the lack of decision making that we do as a culture.
Examining things is so hard.
Yeah, 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 comfortable. It is uncomfortable.
Oh, it is.
Yeah,
What that I love about medical aid in dying is that when I fill out the death certificate, I put the underlying disease as the terminal diagnosis. I don't put that the patient died from medical aid in dying
right.
medicines. I put cancer or Lou Gehrig's.
Yeah, beautiful.
It's really helpful for the patient and their family, but of
Mhm.
course, what's most important is that it's helpful for their life insurance. It means that their life insurance is still paid out. For some people, that's an enormous consideration, and maybe
Mm,
something they've been paying into their entire lives, and
right.
it's such a comfort to know that that will not be wasted.
Right, and that's something if people are working with another doctor that they can bring up in the consultation and make sure that that's gonna happen, and that would be in my book, that would be another marker of lucidity.
100%. Oh, I had someone who I had a patient who wanted to take the medicine, but he wanted to take it in January because he wanted his son to be able to take out the maximum amount from he had some incredibly, detailed and very sophisticated reason for choosing it.
Yeah,
Yeah. It always breaks my heart when financial reasons are the reason that someone is taking these medicines, but it wasn't that he was taking them for financial reasons, it was simply that the timing was very well
yeah.
considered.
It
Um,
just shows you how beautiful human beings can be because it's his willingness to suffer for that extended time so that his son can be set up better.
I
That
mean,
I think that's gorgeous.
people work their entire lives to benefit their children.
Right.
This was his last act of selflessness towards his
Mhm.
children. I thought it
Yeah,
was a beautiful gesture.
yeah.
Uh, so that's as I would like to pretend that no one has to worry about money ever, but
Mhm.
I realize that
Mhm, mhm.
that's not true.
That also is not the culture we live in.
You're so right.
Oh. You don't even have the right to medical care just simply from being alive.
Oh, I know.
You have
I
to
know.
work,
Breaks my heart. I
right?
did medical school in Cuba, which
Well,
is
that's a beautiful
just a
medical
very
system
different
out here,
culture.
yeah.
I love it so much.
I taught high school for years, and my low income kids that wanted to be doctors, I used to say, "You should look at Cuba." I'm just
You should
kidding.
look at Cuba.
They look at Cuba's medical school system, and they would take you.
Absolutely,
They would.
absolutely, and I graduated from medical school with no debt. I'm very, very,
Oh, did you do that?
I did, I did.
Yay! Because that's what I was always trying to get those kids to be able to do. It's the mama in me that was never far away from my high school classroom was, "Okay, you wanna be a doctor? But yeah, how can you do this where you're not gonna be saddled with debt for the rest of your natural life?"
Yeah, it's a
Yeah.
good way to go.
Yep, yep. So let's continue now. If you've got your diagnosis,
Yes.
you've got your prescription, you've done the 2 consults, and you've got your prescription, then what happens?
There's one more piece of paperwork. You have to fill out a written request form and submit it to one of those doctors, and then the attending physician, who is the prescribing physician, will prescribe the medications for you. It's 5 medicines: amitriptyline, diazepam, digoxin, phenobarbital, and morphine,
Mhm.
plus 2 anti-nausea medications, ondansetron and metoclopramide, that you take about half an hour to an hour before the medications. So once the attending physician has written that prescription, you pick it up at a special compounding pharmacy. There are about 6 pharmacies in California that are able to handle these medications in these quantities,
Mhm.
because imagine it's an enormous quantity of medicine. It's a
Mhm.
gigantic overdose.
Yeah.
Um, and once you picked up the prescription, you choose the day that you would like to die. Some people take it that very same day. Some people like having it nearby, as the most expensive and most dangerous teddy bear I've ever seen.
I'd be one of those.
It's
I'd be looking at it for a couple days at least,
It's completely understandable. And in fact, some people die with the prescription in their house. They keep it for when it just gets too
just
bad.
in case.
And then they find that every day it's just not quite that bad and they
Mm,
don't need it today. And
right.
that's fine.
I think that's beautiful. I think
It,
that's the best outcome in a way,
I think it
in
means
some
that
cases.
justice did its job and that the patient was able to die peacefully and really enjoy their life as best they could till the very last day.
Right.
And I see that as a completely acceptable outcome.
Mhm.
Yeah. Having said that, I do have to say that you do have to send the medications back because those are exquisitely dangerous. Leave them alone in the house.
Mm, true, but the person who died doesn't have to do that. The family.
That is someone else's problem.
So now we have the meds. Do you have
Mhm.
to pick it up yourself, or can someone pick it up for you?
Sometimes the hospice nurse will pick it up for you, which I think
Mhm.
is so kind. And sometimes a family member will pick it up. You don't have to pick it up yourself.
Could a
On the
senior
patient,
do that?
yes,
Yeah, I
100.
think that would be a great, service that would be willing to provide.
It would be a very helpful service.
I thought he would do it.
And then
'Cause it's
the
gonna be a drive, and these people are not well.
it's
But
often a drive. Yes,
yeah,
and no one who is dying should have to drive to the pharmacy
right?
and try to
For
get the medications.
hours possibly. If California's a big state, if there's only 6, depending on where you are, it
It is
could
a
be a
big
drive.
Well, fortunately, some of the more expensive pharmacies will deliver, so I've had to use that
Oh,
option a number of times, and that's
con
fine.
concierge service.
See, there's pharmacists. Absolutely. I mean, as you say, California is a gigantic state. If they didn't deliver, we'd truly have a very difficult time getting some of these medications. I had a patient in Mount Shasta,
Right.
and the closest pharmacy was in Sacramento, so they obviously delivered. I had a patient who lived in a town that was so small, though, that FedEx didn't deliver on Saturday, so she had to wait over the week. She wanted to take the medicine on Saturday, but the medication didn't come until Monday,
Right.
unfortunately.
Right. But I was thinking about those logistic problems because people die everywhere. They don't just die in cities.
Honestly, the amount that I've just the medical side of medical aid in dying is pretty straightforward.
Right.
Medications, gigantic doses. The logistics around it are what are interesting. The personal side of it
Crazy.
is a very interesting part, and the logistics part is the fiddly bit.
Right.
Um, and it's, if you're going to say patient centered, the logistics can be just as important as the medicine, is getting the medicine to the person by the time they need it.
Right.
Uh, it's the devil's in the details.
So let's go into those details. When someone is ready and they've had their last dinner, last supper, I can't help myself. Um,
Right.
when they've had their last supper and everything's done, um, what can someone be with them? How does this work?
Not only can someone be with them, recommend that someone be with them.
Mhm.
You don't have to. If the patient wants to take the medicine all on their very own, they absolutely can.
Right.
But why wouldn't you want to have your family and friends near you?
Right.
Interestingly, these friends and family or doulas or nurses can help you mix up the medication. You have to take it, but they can help you mix the medication.
Mhm.
The
Mhm.
medication is approximately a handful of white powder. You
Oh,
mix it in about a third of a cup of either apple juice or simple syrup. And then
oh.
you mix like crazy. Pretend
And
you got
it's nasty if you're mixing it with simple syrup.
Yeah, that's right, that's right. So you mix like crazy. You mix until your hand is tired, then you switch and you mix some more because the powder wants to suspend out. So you have to get the
Mhm.
powder as liquid as suspended as possible.
Mhm.
Then the patient can decant it into a fancy goblet if they want. They can drink it straight from the bottle, or some of my patients use a boba straw, a big thick
Mhm.
one,
Mhm.
to get it out. I had a patient with ALS who wasn't able to move any part of his body, so his wife held the cup and he was able to drink from the straw.
So I was wondering about that too. I'm glad you said that because I was gonna like, how much is it not like, is that helping?
Yeah.
Um,
You can help, but the patient has to be able to display agency. So the wife can
the
hold
sucking on the straw
in
is agency.
his mouth. Yeah,
Yep.
but he has to sip on the straw.
Right,
For example, she couldn't hold it to his mouth and pour it. That's
right,
not showing agency.
right.
A lot of patients have things like esophageal cancer or
Mhm,
gastric cancer. They might
mhm.
not be able to swallow anything at all, or they might have such terrible breathlessness or nausea that they're unable to swallow a large amount of liquid. And so what a hospice nurse can be very helpful for is placing a rectal tube. So you can place a rectal tube and then someone can put the medicine into a large syringe, a 50
Right.
milliliter syringe,
Mhm.
and prepare it. Again, and they can hold the syringe, but the patient has to depress the plunger. So the
I
patient
see.
has to show that they're able to do it themselves.
And does
And
that take a lot of strength?
it takes a certain amount of strength, yes, because the liquid is quite thick and it's a
Right.
50-liter syringe. That's a big one. So
Mhm,
you have to exert a certain amount of pressure. And for
mhm,
patients who have, intestinal issues and bad arthritis, that can be a challenge.
mhm.
Having said that, I've seen a lot of people be really motivated and people
Well,
find
yes,
a way.
yes,
Turns out if you have to push that plunger down, you will push that plunger down.
right. I
I
think that they get an adrenaline boost like a mother lifting a car up a baby if they want it that
oh,
way.
and I've had patients who really didn't want a rectal tube and have figured out that maybe they actually can swallow about a third of a cup of calories.
That would be me.
It's it's
I'd be
so
like looking at that stuff going, "Oh, I don't think I can drink that."
you want to do, yeah.
Yeah, yeah,
And they say, "Oh, well, we'll do a rectal tube." They say, "Oh, actually, I think I can drink it." Yeah,
mhm, yeah.
they change people's
So
minds.
there is there no, universe in where there's an injection or a pill?
Again, we would love for that to be the case. For the moment, Switzerland is the only country that allows for injectable medications for
Mm.
this, which is so interesting because, a much darker side of this is that for the death penalty, we are able to use injectables. But
Well,
for
I was thinking about that.
Mhm.
You know, how when they're talking about how they use 2 drugs for that, and it's kind of off topic, but it seems like they should be able to get the same that cocktail for people on death row. They
If
seem
you
to be
could
having
our cocktail intravenously, that would work incredibly well. I mean,
exactly.
we're using gigantic doses because we know that oral absorption is just not as good as intravenous uh,
Right,
absorption.
right, right.
Now, we the doctors would love for this to be an intravenous option, really,
Mhm.
and so many of our patients requested. A lot of them have a line already, so they wouldn't need to
Yeah,
share
so simple.
so much so.
I'd say the
Yes.
majority probably have a line already.
The majority do, and you can imagine that the difference between plunging a plunger like this and plunging a plunger like that,
Right.
it's a huge difference. It'd be so much easier.
It
Yeah.
seems like, we're making this unnecessarily hard for people
Yes,
sometimes
it does, doesn't it?
out of our weird sense of morality.
Yeah. Again, there's so many things we really want it to be as easy as possible for the patient and we want it to be covered by insurance. There are two things that we really think would improve the experience for our patients and improve access for our patients, which for me is the most important thing.
Excellent. All right, next thing, once you've taken the medication, how long does it take and what's the experience?
Yes. So we have no idea what the actual experience is.
Okay.
What we've seen is that one, unfortunately, the medication is exquisitely bitter. So you're gonna go, it's like drinking a really strong whiskey. Then people fall asleep within 10 minutes. So I
Mhm.
actually tell people that if you're gonna say goodbyes, make sure you say them before the
Very important.
don't run out of time.
Mm,
And then the patient is asleep. They're in a profound coma and they're not feeling anything at all. We wonder if perhaps, based on our medical experience with comas, we wonder if perhaps the patient is able to hear something. So I always encourage families to play music, to keep speaking to their loved one, to say
mhm.
something that they think bears repeating. I always encourage families to continue speaking to their patients, but the patient is not experiencing any pain.
Right.
Then over the course of minutes to hours, their heartbeat and their breathing will gradually slow down. I've had patients die as little as 5 minutes after falling asleep, And I've had a patient die as many as 21 hours after falling asleep.
No, that's quite a range. That surprises me.
That is a huge range. The most people die within 2 to 5 hours. That's
Mm,
really the majority of patients die within 2 to 5 hours after falling asleep. But everyone is different. Some people are really at the end of their rope and they die so quickly after falling asleep.
right.
Some people are younger. We found that people with brain cancer tend to die more slowly. A lot
Mm,
of people at the end of their lives have digestion issues. They have horrible constipation, or their gastrointestinal tract isn't as good as it used to be. Maybe they haven't eaten it very well in a few days. And patients with those medical problems tend to take longer to die after they've fallen.
mm,
So
mm.
we have ways of maybe predicting who will have a shorter death and who will have a longer death, but it's not an exact science, not even remotely.
Everyone's an individual.
Everyone's an individual, and it's such a complicated process and
Right.
such an interactive process with the medications that we never know exactly how long someone will take to die fully.
Right. I've had experience of someone dying and feeling like their presence was in the whole room
Mhm,
around me,
mhm.
and I'm wondering now about that time that it takes, that window, um, and I'm really glad to hear that people are encouraged to talk to the loved one because it could be that experience of just being loved.
Yes.
That
And we obviously have no idea, but what could possibly be wrong about telling your loved one that you love them over and over again until their heart stops? I can't think of anything more beautiful.
Me either. Me either. And honestly, would love to sing for someone then.
Oh, yes, that would be so
Yeah.
beautiful.
That's what threshold choir means.
Yeah, right? This is the actual threshold.
Right.
And this is another time when death doulas and hospice nurses are invaluable because of course the patient is comfortable after 10 minutes, they're unconscious, they're out of pain, they're no longer suffering. But for the family, it's still very important for them to keep vigil. And I find telling them to play music and speak to the loved one is probably helpful for the patient, but is also very helpful for the family. I also find it's very helpful to have someone who's had a lot of experience with dying patients to be able to reassure the family that what is happening is natural. There's always kind of this fear that it's not going to work, that it's not going smoothly. And I think people who have seen patients die, multiple patients die, know what's normal and know how to explain that to the family.
Mhm.
Yes, breathing is normal. Yes, it is normal for them to have a gap, but then maybe have less of a gap and for it to maybe not be as regular or as directional as we think it should be.
Right. And I also think we can't probably say enough that the person is not suffering because
Yes.
that would be my worry if it was
Yeah.
someone that I loved,
Mm.
that inside that there was suffering. And it would
It's
help me to hear that it's not.
all anyone cares about. It's the whole point of
Right.
this. Isn't it?
Right. It is the whole point.
Yes. I say that. Yeah, I agree with you. I must say that about 1,000 times. You will take hours to die, but you will stop suffering after 10 minutes. And that can be
Right.
so reassuring.
And that moment is so interesting to me too. I would love to know, I know we can't, but I would love to know what's going on
Oh,
in those moments
I
because
agree.
it's
I,
entirely possible that what's going on in those moments is beautiful.
yes. I certainly hope so.
I do too.
I did want to mention that the Academy of Aid in Dying Medicine is a group of doctors who do medical aid in dying. And what they've done recently is they've started tracking medical aid in dying deaths. They've asked how long it takes for someone to take to fall asleep and to die. And we're really trying to use this information to help families know what is going to be the process because if medical aid in dying allows the patient to regain a little bit of control over their death, it can also be very helpful for the family to know a little bit what to expect.
Mhm.
So we we've gone undergone a lot of changes in the medications that we use. We used to just use a lot of secobarbital. That used to be the only medication we used. It worked 100% of the time, but if you think that 5 minutes to 21 hours is a long period, this had a minutes to days period.
Oh,
We had just no idea how long someone would take to die after falling asleep, and that was very stressful for the family.
yeah.
just emotionally, but also logistically. People need to sleep, people need to eat, but everyone was just worried about missing that final moment, that last breath. And so, a lot of what the Academy of Aid in Dying Medicine is aiming to do is help the death be a little bit more consistent so that we can really advise people, say, hey, you will fall asleep after a certain number of minutes. That seems to be fairly constant between patients. And you will die after a certain amount of hours. It gives people this sense of agency and allows them to really plan the moment in the way that they intend to.
Right. Well, I would just put in here that if you are a death doula listening to this, that there's a volunteer program through the Academy of Aid in Dying
Oh,
that
wonderful.
that exists to hook up doulas with people with this intention.
Yes.
And so that can be, like Googled and looked into. So
And it's so
then
yes.
moving on, um, after the patient has died, what happens then?
Yes. Then we treat it as an expected death within a hospice. So
Mhm,
if the hospice nurse is there, they can declare the time of death.
mhm,
When the time of death is called, the mortuary is called, and the death certificate can be filled out either by the hospice that the patient is registered with or by the doctor who prescribed the medication.
mhm.
To myself, because that's often me.
Yeah.
And the other reason, death doulas and hospice nurses are incredibly important for so many reasons. Hospice nurses are logistically important because if they declare the time of death, then the rest goes very smoothly. The mortuary comes, the patient's body can be prepared for whatever burial service the family has in mind.
Mhm.
If a hospice nurse is not there, and this has happened for me for a couple of patients who have taken medical aid and dying medicines, you have to call EMS. You have to call ambulances. And there's no way to call an ambulance such that they will arrive without lights and sirens, which I think is really unfortunate. I think that's a big gap
It's
in our.
almost assaultive.
It is. It is. And because medical aid and dying is, I would say, unevenly understood in different parts of California. Twice, I've had the emergency services call the police because they thought that my patient's family had basically committed homicide or that the patient had committed suicide.
Mm,
And fortunately, the patient's family had the presence of mind to call me. I was able to speak to the police directly and explain to them the law and the nuances of the law. But there are places in California that have not yet seen a medical aid in dying patient and therefore don't know exactly what to do. And
that
so,
could be a trauma on
oh,
top
can
of
you
all
imagine?
the grief.
Well, you said the lights and sirens are assaultive, and I 100% agree. And then having the police show up, I just can't even imagine how that felt for the family.
Right.
That's so
You're at your most vulnerable.
when you're at your saddest and you just want to spend time with your loved one.
Yeah.
Absolutely. And so, for that reason, while death doulas are incredibly valuable in the dying process, I would really put in a plug for having a hospice nurse there, either during the dying process or shortly after the death, because they can help avoid all those terrible, terrible situations.
Right. And if you're in a hospice situation, I would think we should be able to arrange that.
It's almost always possible.
Yeah.
It's yet another reason that we're trying to get the time of death to be just somewhat more predictable. It really just
Mhm.
in the current system in which we work, it just helps things go more smoothly. So
Right.
that's cool.
I also think, though, there's a way in which we used to die, right? Before we had all this big medical apparatus, when people were around and it was unpredictable and it took what it took and gifts in exchange took place kind of in a liminal space, um, that, it's not such a bad thing. It's actually a little bit more like how it used to be.
Yes. And if someone dies in their home without hospice, without medical aid and dying, but they've come to terms with their death and they've managed to process their death appropriately and they feel comfortable while they die. I think that's wonderful. I don't need to over medicalize anything, even for patients that have medical aid and dying. I think that whole range of experience is perfectly acceptable within, this very holistic way of treating end of life. So I agree.
Right, right. I come from a culture where wakes were in the living room, that's,
Wow.
yeah, and everybody just raised a glass and talked about them. And before long, you were joking and telling about the time they did this and the time they did that,
Sure.
you know, and I think that's really healthy.
I think that's great. Yeah, why would you pretend that there's someone they're not? All the stories should come out.
Yeah, and you talk about them as if they're still here.
I think that's amazing.
Yeah, because maybe they are. One last part to this I want to talk about is how much does it cost? Like, let's ballpark this thing for people.
Absolutely. Yes.
What
And
can you expect?
that is so important because as much as I would like to pretend that no one has any considerations for money and that's no
Right,
problem
right,
anyway,
right.
that's not the system.
We don't live in that country.
Ah, I wish. And we've noticed that medical aid in dying is accessed most frequently by patients who are white,
Mhm.
wealthy, and educated. And that's there's assuredly a whole number of reasons that goes into that. And there are a lot of reasons that might be very good reasons that other groups of people are not accessing medical aid in dying, but lack of being able to finance it and lack of knowledge about it are not acceptable reasons. So
Right.
yes, let's talk about cost. If you can go through the medical aid in dying process through a large organization like Kaiser, UCLA, and UCLA, all the doctor's fees are covered. You only have to pay for the medication, which will set you back somewhere between $500 and $800, depending on which pharmacy you use and how much the shipping costs.
Mhm.
Mentioned previously, there are some pharmacies that accept Medi-Cal. It is vanishingly rare, and it's just because the number of plans that cover the medications are very rare. So it's vanishingly rare that a patient will have the exact correct combination of insurances that allow the medication to be covered. The complaint that I've heard with these institutions is only that, like many things, they're a little bit impacted at this point in time, and so it can take a long time. At which point, many patients pivot to a private doctor. I'm one of those. I'm one of a network of private physicians in California that provides medical aid in dying separately from a large institution. So for patients who aren't with a large institution or who would like to do it in a more timely fashion, they would go to someone like me. And I can tell you that it costs anywhere between $1,700 and $8,000, depending on which doctor you speak to. 1,700 is in a more rural area where the costs are not as high, and then 8,000 is there's only one provider I know who charges that much, and he has a more concierge, holistic, um, kind of more interdisciplinary package. Most physicians charge between $2,000 and $4,000, which will cover both doctors, the
Mhm.
medications themselves, and to all the paperwork that is required by the California Department of Public Health. So it's a bit of a package.
Mhm.
Um, and most people organize it like that because the patient is already dealing with probably at least 3 different medical providers,
Right.
and really try to make it as simple as possible.
And
Now
probably more.
yeah. Now, having said that, every doctor that I know who provides this service provides it on a sliding scale because everyone who does this work is just waiting for insurance to cover it and strongly believes that everyone should be able to access this medication regardless of their ability to pay for it. So the process itself is very expensive, but I don't want patients to feel discouraged. They should always reach out, and there's always a way.
Right. And I think that you could probably contact the Academy of Aid in Dying for advice, right? I bet they have a website and
They do.
ways to contact them.
Yes. So patients who don't have a way to do it through their normal medical doctor can
Mhm.
contact either the Academy of Aid and Dying Medicine or End of Life Choices California. Both of these are organizations that have referral systems. So all you say is, "This is my name and I live here," and they will give you the name and number of doctors who live in your area. And for patients who live in the middle of nowhere, they will give you the number of doctors like me who can do this by telehealth.
Right.
Fact, I would say most of us doctors who do this by telehealth because even our patients who technically live in the same city don't want to come to our offices. They want to stay at home. They do not want to leave bed, and that's very understandable.
Right.
There are a couple of physicians who will do house calls, which is a wonderful service to be able to offer. That's obviously very location specific, so that's not available to everyone. But for some people in Los Angeles and San Diego, there are doctors who can do home visits.
Mm. I'm glad you broke it down for me because when I heard how much it cost at first, I was kind of like, wow, that's so expensive and usually not covered by insurance. Not
Yeah.
in a narrow the field for a lot of people. But it also includes the cost of the medication, which is pretty expensive too.
It does, and because there are so few doctors, there's not a way for a physician to only do this as their job, and
Right,
that's sometimes why it can be a little bit more expensive, is
right.
to have to find a doctor who's actually able to do it.
And it brings me back to the priorities of our culture, especially medical culture, that you would think that this would be much more supported. I mean, we're willing to have people on extensive life support, very expensive per minute life support, and very poor quality of life, which would be, extremely expensive to the insurance company. We pay for that, uh,
Yes.
but we don't pay for the choices that are
That
sane.
people want to make.
Yeah.
Interestingly, it is, I agree, it's very expensive, and we strongly want insurance to cover it because we don't want access to be a problem. Having said that, I know that there are people in the field that are concerned about it being subsumed by organizations because they're
Mhm.
worried ultimately about a conflict of interest or
Right.
just dueling priorities. Sometimes people actually take comfort in knowing that the person who's providing their end of life medications is separate from the person who's treating them. There's unfortunately, there sometimes can be issues of trust. What is a doctor trying to accomplish? Are they trying to cure you? Are they trying to kill you? And that should never be a question. It should be it should be an integrated continuum of the is most patient focused.
Right.
But
That's
but
the key, though, isn't it? Like, who's in charge here? If
no
it's the patient that's in charge, then a lot of those conflicts of interest can evaporate.
100%. But because there's still this power dynamic of the
Right.
doctor knowing more than the patient, I think there's this issue
Exactly.
of, again, of trust and competing priorities that we really have to work out and that we haven't worked out yet, but that I'll be interested to see us work out as this becomes a more common uh, process.
Yeah, even if you kept it separate, which I can totally see the value of, being around end of life care as much as I am,
Mhm.
I can tell you the people that choose to work in that field are just different. It's just something about people who are willing to walk into that situation, and I would want someone like that on my team, um, as opposed to
Isn't it?
our, very clear-eyed, scalpel-mind doctor. Um, I would want that. So, but I think the solution is just having insurance companies cover it.
I
And
agree.
then you take all those concerns go away. If it's the patient is the one with power and the insurance companies just pay for it, then all of a sudden it's just dignity everywhere.
I truly hope that's what we get to. Of course, what I really hope is that we develop a single payer healthcare system and we don't have to worry about
Yes.
fees at all. That's just me being a socialist.
Oh, doctors, you just want so much.
I just love I just
It
love
would
the
be so much less expensive if we would just do that.
well, of course, and that's what I would really like. I hope you're right. I hope this becomes integrated into insurance soon. It's only been 10 years, so I have to imagine its time is coming.
Right.
Uh, but I wonder if it's something that's going to have to wait until all the states have adopted that, and that feels very far in the future. So I truly hope that we're able to work out the insurance
Yeah.
before that happens.
For some states, that's very far, as in maybe never.
As in, we never, as in, I don't know when that could happen.